Okay. Uh, Good morning, good afternoon, good evening, everyone. My name is Andres Salis. I'm the head of strategic communications on the Sustainable Health and Equity Movement. I want to welcome you all here in the last edition of our webinar series, in which we are honored to receive Sir Michael Marmot and to keep the conversations about how to think on ethics and metrics related to inequality. Today, I will be quicker and will give the floor to Juan. Professor Juan Garay, so he can introduce the series and the webinars and start the work that we'll be doing today. Juan, you have the floor.
Thank you. Thank you so much. Can you hear me well?
Yes.
Okay. So we will be talking today, and it's really an honor to count on Sir Michael Marmot with us today on the geography of global injustice, the state of the burden of global health inequity, but with some lenses on the local dynamics and local action. Michael will elaborate upon. I will briefly, next one, remind what we've been talking about so far. We've had 3 webinars before this one to set the scene. The first one, we spoke about the ethical challenges in terms of sustainability. And we, with the Planetary Health Alliance, we discussed what is the ethical threshold of carbon emissions, which really conditions how we are living the planet for the next generation, and which are the sustainable models we should be looking at, which rules out most of the high-income countries and high-income regions that bear the highest human development index. But if we follow the path till now, we would need a number of planets. We continue talking with the Global Footprint Network and some scholars in other regions about the ecological footprint as well. And with both, with the carbon emissions footprint and the ecological footprint, we selected a number of sustainable models. We then went on to relate those thresholds with the economic models and the economic thresholds. And we discussed with some economists which would be the sustainable and equitable models of human well-being, which we should relate to progress collectively, globally, to better health, but sustainable for the next generation. And today I will introduce the geography of the analysis, comparing those sustainable models with the rest of the world, and how has it been evolving in the last 60 years, and the main features. And then we will have Michael bringing us to reality, to the local level. Next one, Andre. So in the selection of healthy, sustainable, and replicable national and subnational models or references, we took, as I said, the ethical threshold in terms of carbon, ecological footprint, and biocapacity per capita. And we selected healthy, replicable, and sustainable references in terms of well-being above world average, economically replicable models with GDP, GNI in different units below world average, and ecologically sustainable country, which is the most limiting factor. Like I said, biocapacity per capita below world average, and carbon and ecological footprint below the ethical thresholds we need to respect if we want to keep the resources and the living conditions in this planet for the coming generation. Next one. So at present, there are only 20 countries out of the almost 200 countries in the world that meet the sustainability criteria. They respect the ecological and the carbon footprint for the coming generations and for the recycling capacity of the world. Economically replicable countries are mainly in the tropical and subtropical regions. Most of the high-income regions on the other ends have an economic activity that is not compatible with sustainable criteria, and we would need a number of planets to keep up to the level of production and consumption. And the healthy countries in the world are mainly in most of the Americas, Europe, the Middle East, China, Southeast Asia, and Australia and New Zealand. Next one. With these criteria, we could identify only 26 countries that have met healthy, replicable, and sustainable criteria during at least some years in the period of 1961 to 2023, when we have comparable data. Only 3 countries have met those criteria in 2023, Sri Lanka, Cape Verde, and Bangladesh, and only one of them met all criteria throughout the study, with 2 exceptions, 2 years in 2003 and 2006, with excess young male deaths during the 2 years of civil war in Sri Lanka. So it's a very limited number of countries that have met these healthy, replicable, and sustainable criteria we can relate to. Next one. If we look at subnational references, we only started looking at some of the sub-regions in the 10 largest countries, and the regions in those countries that met those healthy, replicable, and sustainable criteria I was referring to were a number of them. I won't list them: in India, China, Russia, Indonesia, Pakistan, Brazil. None of the states in the USA or in Nigeria met those criteria. In the USA, because of sustainability criteria, none of them met those, and Nigeria life expectancy. Next one. So it's interesting that, and I'm sure Michael can have a comment on that because he knows the country. Sri Lanka is an interesting case, but as we go identifying subnational references of human well-being which respects planetary boundaries, we will probably expand our reference population. But Sri Lanka maintained a balance with nature and used less than half the world's average GDP per capita, enjoying a life expectancy which is 10% higher than the global average, 8.5 higher in men and 10.5% higher in women. So it's an interesting case to look at. And we compared over 400 indicators between Sri Lanka and what we call lower health efficiency countries, countries that have higher GDP per capita than Sri Lanka, yet lower life expectancy. And the main four features that stand out in the comparison is that Sri Lanka has a higher rural population share. It's over 80%, much higher than what we call the low health efficiency country. 55 countries with higher GDP per capita, yet lower life expectancy. Its trade policies are interesting because they have higher taxes on international trade and import duties, protecting local production and consumption. There are a number of interesting health factors. For instance, they have a lower average body mass index than those countries, and lower calorie intake per capita, and reduced prevalence of overweight. And it's also unique as the only lower middle income country with 100% health insurance coverage, despite allocating a lower share of GDP to health than the other countries, and having a higher out-of-pocket health expenditure, which are factors that need to be analyzed in greater depth. Next one. So if we compare the mortality rates of Sri Lanka with the rest of the world, and we see which is through the adjusted mortality rates, we can estimate the number of excess deaths from that sustainable reference of well-being. So that's analyzing over 7 million data. The recent UN Population Division has issued a report of single-year analysis from 1960 till now, with some retroactive adjustments, and single age. By every age year they have estimated in each country, and by sex, the mortality rates. And by comparing, as I said, our reference with the rest of the world, we can identify the net burden of health inequity, the excess the number of excess deaths from that sustainable, how WHO calls it, feasible level of best health, and the proportion of all deaths that exceed those healthy, replicable, sustainable levels, which we call relative burden of health inequity. Next one. So the results are as follows. Throughout these last 60 years, it has decreased slightly from 1960 till the 90s, but it remained quite stable since the 90s, with around 15 to 16 million excess deaths every year, and around 25% of all deaths, which are in excess, and one would say they are due to global injustice. Next one. So this is the distribution of countries most affected. India has the highest number of annual excess deaths, with over 3 million, almost 20% of the world's. Nigeria, over 2 million, almost 14%. Together, they add 1/3 of all excess deaths globally, and they're followed by large populated countries like Pakistan, Indonesia, and Democratic Republic of Congo, with 5% each, and then Ethiopia, Russia, Philippines, and South Africa. Next one. In terms of relative burden of health inequity, which is a more comparable indicator among countries with different population, with close to 90%, Chad has the highest relative burden of health inequity. 90% of the deaths taking place every year in Chad are in excess of the model in South Africa, in Sri Lanka, and is followed by Central African Republic, Nigeria, Somalia, and Niger. In 58 countries, deaths in excess of those feasible levels, sustainable levels, are more than half of all deaths, and most of them are in sub-Saharan Africa. Next one. And this is another interesting indicator, which is the life years lost to global health inequity. So we multiply the number of excess deaths by the median age of death, and estimate the years lost to premature mortality in those countries. Nigeria has the highest, it's followed by India, and then followed by Pakistan, DRC. Next one. Next one. So next one. Next one, Andrea. Yeah. So it's interesting also to look at the comparison between the relative burden of health inequity, the proportion of deaths in excess of sustainable models, in males and females. And there are higher levels of male than female relative burden of health inequity in Russia and former Soviet Union countries. But on the other side, there's higher female than male relative burden of health inequity in India, Pakistan, and part of the Arab world. Next one. It's also interesting to look at the sex expectancy, life expectancy by sex, the gap ratio to world average. So we looked at the countries where female health is relatively to world average, better off than men's. And that happens in Russia and former Soviet Union's republics, Namibia, Thailand, and Vietnam. But the sex gap in life expectancy is lower than the world average, relatively worse off than what would be expected for women in regions where women's rights lag behind us: India, Afghanistan, parts of the Arab world, and Muslim Sahel. But it's interesting to see that also in some high-income development, advanced human rights countries as Central and Northern Europe, notably Scandinavian countries and Australia, New Zealand, that sex gap in life expectancy is lower than the world average. It's interesting to discuss that. Next one. And this is one of the last slides. This is the age distribution of the relative burden health inequity in the world. In general, it's higher in younger age groups, and it decreases with age. It has this hat shape in the higher income countries, where they have a certain level of relative burden of health inequity in some of the countries. In those those age groups between 15 and 45. Next one. And the factors that one would think what is mainly influencing the burden of health inequity, the excess deaths from what is that best feasible level of health. Well, of course, the economy is one, and the GDP and income and the wealth per person influence up to certain level the level of health inequity. And there is a relation between GDP per capita and the burden, uh, and this is an inverse trend in relating GDP and the burden of health inequity. It's highly heterogeneous, though, with the curve flattening above the GDP per capita of our HRS reference country, Sri Lanka, above 4,000, and the 55 low health efficiency countries, that group of countries that has higher GDP, yet significantly, in some cases, lower life expectancy and high burden of health inequity, are outliers in this graph. In some cases, such as the USA, the net burden of health inequity even shows a slight increase at very high levels of GDP per capita. Next one. And that also happens with, well, there is an interesting relation as well between Gini, economic inequality, and health inequity, and the burden of health inequity in terms of global burden of health inequity. There is no clear correlation between the Gini indexes and the relative burden of health inequity in countries with GDP per capita below the world average. It's interesting to look at the contrast between China, with a Gini index that has risen in the last decades up to 0.46, and it has a very low relative burden of health inequity, less than 2%, and India, with a Gini index of 0.32, quite low compared to global averages, yet a very high relative burden of health inequity, although India has around half of the GDP per capita of the HRS reference. In high-income countries, overall health outcomes characterized by high life expectancy and low relative burden of health inequity tend to improve as Gini decreases. So after a certain level of GDP, you can see the impact of Gini in reducing relative burden of health inequity. A very interesting comparison is between Japan, with a Gini index of 0.32, and nil relative burden of health inequity, with the one of the highest life expectancy, and the USA, with a Gini index of 0.47, and still 3% relative burden of health inequity, and a life expectancy slightly lower than Sri Lanka. Next one. So another interesting case is the health expenditure per capita and the burden of health inequity. Similarly to GDP per capita, there appears to be a threshold of health spending per capita beyond which relative burden of health inequity does not decrease any further. The case of the USA, again, is interesting, is telling, because even after adjusting in purchasing power parity, health spending is more than 100 times higher than in Sri Lanka, yet it fails to eliminate the relative burden of health inequity, the comparison of mortality rates with that reference country. Next one. And as I think this is the conclusions, my last slide. Well, I wanted to present this analysis, whereby we've been looking at this for the last 15 years, and every 5 years we use the UN population division data of population and deaths and mortality rates to analyze these excess deaths and the proportion of all deaths which are in excess from those feasible and sustainable models. And Sri Lanka, in Sri Lanka now remains as the only country. And 15 years ago, we had 15 countries. 5 years ago, we had 7 countries. Now we only have 1 country, but we're beginning to analyze many subnational interesting references. And it has interesting features, as I said, in terms of higher rural population, lower global trade engagement, tax-based universal system, and others to be further studied. And in terms of the health inequity burden, it accounts to around 16 million deaths in excess of feasible models, and this is probably an underestimate. It's around 25% of all deaths are due to global injustice in our analysis, and 800 million life years lost every year. India, Nigeria, and the rest of sub-Saharan Africa bear the heaviest net burdens, with Chad experiencing the highest relative burden. 90% of all deaths are linked to inequity. Women globally face a higher relative burden than men, and the sex life expectancy gap ratio with the world average is lower in India, Arab countries, and some higher income countries. Age-specific and regional patterns show that high inequity burdens disproportionately affect children in low-income areas, while wealthier countries face these burdens mainly among young adults. So we are looking at sub-national analysis to identify higher health efficiency sustainable references, and also the relation with economic equity. We've already published a couple of papers we will be discussing in January in the coming webinars, looking at which economic features are seem to be related with levels of well-being which are sustainable with planetary boundaries, and that can be a reference to the world. I will stop there, and we'll have the pleasure of listening to Michael bringing us closer to reality, to local context. Thank you.
Thank you very much, Juan. As always, as someone who is hosting the series and also seeing how your ideas being evolved over time, for me is always impressive how you can combine our existing data and existing units of measure into different ways so we can look at the consequence of health inequalities globally. And now, without further ado, please let's hear Sir Michael in bringing this conversation more through a regular ground. I believe that Professor Michael doesn't need a presentation, but I have one here. Sir Michael Marmot is a professor of epidemiology and public health at University College at London. He's currently director of the UCL Institute of Health Equity, and Professor Marmot has led research groups on health inequalities for over 30 years, working for various international and governmental bodies. Thank you, Michael. You have the floor.
Thank you. And it really interesting analyses from Juan, much to discuss. At Juan's invitation, I'm going to talk about the UK. I am involved in global work, but to give an example of what happens in one country. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. And there's a lot of discussion about the problems with our healthcare system, 14 years of neglect, and the new government is paying attention to that. My concern, though, is with the conditions that make people sick. And as you'll know, I chaired the WHO Commission on Social Determinants of Health. In the wake of that, I was invited by the British government to translate our findings for one country, and the Marmot Review, published in 2010, as Fair Society, Healthy Lives, and then the Marmot Review 10 years on in February 2020. We had initially 6 domains of recommendations: give every child the best start in life, education and lifelong learning, employment and working conditions. Everyone should have at least the minimum income necessary for a healthy life, healthy and sustainable places in which to live and work, including housing. We've done quite a lot on housing recently, and taking a social determinants approach to prevention. We've now added to tackle racism, discrimination, and their outcomes, and pursue environmental sustainability and health equity together, which is the basis of the sustainable health equity movement. So the current context. In England, and it's similar in Wales, Scotland, Northern Ireland, in England, life expectancy had been improving about 1 year every 4 years for women and for men. In 2010, there was a break in the curve. The rate of improvement slowed dramatically. And then in the first 3 years of the pandemic, it fell. So we've had a 14-year period where life expectancy did not improve. I do not know of another period in peacetime in the United Kingdom where life expectancy did not improve for 14 years. If, as I believe, that is related to government policy, it's a damning indictment of what they did. What did they do? Well, there was a new government elected in 2010, the Conservative-led coalition government. In 2009-10, public sector expenditure was 42% of GDP. Over the decade, that 42% became 35%. 7% of GDP taken off annual expenditure. At today's prices, the gross domestic product of the UK is about £2.8 trillion. 7% is £180 billion. They took £180 billion a year out of public sector expenditure. You can't do that and not expect there to be damage. And I think that stalling of life expectancy is part of the damage. In the first year of the pandemic, public sector expenditure went up, and it's been coming down again. And we have a new government elected. It's been there for 4 months. They've already said they will spend more, but let's see what happens. A bit like Juan talked about excess deaths. The way we calculated excess deaths was if you classify people by where they live, classify where they live by the level of deprivation, index of multiple deprivation, you see this social gradient. The greater the deprivation, the higher the mortality. And we said, let's take the least deprived decile as the benchmark. And the higher mortality associated with the level of deprivation below the very top. So we're not talking about poverty now. We're talking about inequality. The level of mortality that's higher than the low mortality in the least deprived, we will call excess. And you can see the excess deaths increase with deprivation. Over the decade, from 2010, there were 1 million excess deaths in England linked to deprivation. Now, there was a social gradient prior to 2010, but it got steeper. And we calculated that of those 1 million excess deaths linked to deprivation, 148,000 can be attributed to austerity. Government, you killed 148,000 people with your policies of austerity. We coined the term proportionate universalism. The whole idea was we wanted to combine universalist policies with the classic Anglo-Saxon approach, was you target the worst off, means-tested benefits. And we said, here's the social gradient, less deprivation, better health. If you focus only on the worst off, you miss the health disadvantage of people who are above the threshold of intervention. So we said, universalist policies with effort proportionate to need. What did we get post-2010? We plotted the life expectancy of every local authority in England in 2010-12. And against that, we plotted the decline in local government funding per head of population. Look at this. The shorter the life expectancy in 2010-12, the steeper the subsequent reduction in local government funding. Now, the majority of local government funding comes from central government. They declared war on local government, but in a regressive way. the shorter the life expectancy, the more they cut the funding. My kindest explanation for this is sleepwalking. They didn't know what they were doing. But it looks pretty systematic. It looks to me immoral. I could go on with bad news, but I want to give you some good news. Firstly, I'm co-chairing the Global Council on Inequality, AIDS and Pandemics with Joe Stiglitz and Monica Gengos from Namibia. And I went to the G20 preparatory meeting in Salvador in Brazil in June. And then we met in Rio alongside the G20 health ministers at the end of October. And the G20 health ministers, for the first time, committed to tackling the social determinants of pandemics. People were saying to me, congratulations, congratulations. And I was thinking how my life is diminished. We released a report of the Global Commission on Social Determinants of Health in 2008. And only 16 years later, we get into paragraph 15 of a ministerial statement and its grounds for celebration. As my daughter said to me, even a baby step is a step. The Italian National Institute of Health, why am I showing you this website? Well, keep looking down, Officio, Marmot cities for reducing inequality. They've launched an Italian network of Marmot cities, building on what we've been doing in the UK. And this is what we've been doing. The English city of Coventry declared itself a Marmot city. Greater Manchester said we'll be a Marmot city region. Cheshire and Merseyside, which contains the city of Liverpool, said altogether fairer. We did a report for them. Lancashire and Cumbria, Luton, Waltham Forest, Leeds, Gwent in Wales. We will have 52 local areas by early next year. All of these places have declared themselves Marmot places. We just kicked off 2 years of work with Scotland. They want to be a Marmot country. And we'll have 3 Marmot places in Scotland, South Lanarkshire, North Ayrshire, and Aberdeen, Oxfordshire, and on it goes. It's really exciting. And local government, healthcare, the voluntary and community sector, public services, business and the private sector, we'd quite like national government to come in behind what's happening, and let's see what the new government does. And we say 3 things in these Marmot places. My 8 principles, system change and culture shift. In other words, they actually say the whole system needs to be oriented in acting on these 8, which leads to a transformational process. Liverpool says it will launch as a Marmot city in 2025. Coventry working across sectors, Coventry Job Shop, Ambition Coventry. The town of Luton, north of London. I was in this small community in Wales on Friday, Torfen, and to my surprise, here's the cover of their report, a Marmot Council. Wow, bit embarrassing, really. And as I said, we've kicked off 2 years of work, a collaboration on health equity in Scotland. And we've got business involved. Legal & General, a giant insurance company, approached me and said, what could we do to act on health equity? Indeed, what could business do? And we said 3 things. good quality work, pay all employees a real living wage, good benefits, conditions, hours of work. Think about your products and services. If you're the tobacco industry, we can't work with you. If you're the food industry, which side are you on? Are you going to be an instrument of ill health? We all require the food industry. Most of us don't grow our own food. Are you going to be an instrument of poor health or good health? Which side are you on? And the wider impact on the community, partnerships and procurement, environment, and the like. And healthcare, of course, is important. One of our collaborators, the East London Foundation Trust, a public health doctor, said, hey, we could take your report for industry and apply it to a public sector organization, the East London Foundation Trust. We're a training and employment provider. We need to think about our service users, clients who use our services, and our impact on the wider community, and the principles of proportionate universalism, universal and targeted. We're working with Barnardo's, the children's charity, and we've got 3 areas that are developing new approaches: NHS social value procurement, early years communication skills, and safe spaces and life skills for 10-year-olds. And go through this, but these are positive comments that have come from various Marmot places. So, for example, in Greater Manchester, the City of Manchester produced its own report, Making Manchester Fairer, which began out of the Greater Manchester Marmot Review. It's owned by all partners. It focuses on the wider determinants of health and is the beginning of a long-term ambition to put health inequalities and health equity at the forefront of people's minds. And we're getting this from all our places. We've put in place monitoring systems to see if indeed we're making a difference. And when Keir Starmer, now the Prime Minister, was leader of the opposition and he launched his health mission, there was a technical document supporting his health mission, and it said the next Labour government will amplify the approach of Marmot cities like Greater Manchester and Coventry by making England a Marmot country, tackling the social inequalities that influence health. I'm trying to hold them to it. Come on, you said you're going to do this. We're watching. Come and do it. And when we launched the WHO Commission in Chile, I quoted Pablo Neruda, and I think it's still appropriate. Rise up with me against the organization of misery. Thank you.
Thank you, Michael. Always a pleasure to hearing you and see how your work is spreading around. And I like this Marmot communities and Marmot country seems like an inspiring idea, one that can lead us towards a less catastrophic future than the one that a lot of people are predicting around. I would like to open the floor for questions and comments and reactions from our audience. Correct, Juan? That's what we intend to do. I don't know. There is no question on the chat. Diana, did you see any question? Okay, so
no, we don't have questions.
Thank you. Juan?
If I may, to break the ice, and I hope some colleagues come in, because it is really a privilege to have Michael sharing with us his thoughts and his vision and actions. Michael, what we have seen at global level is what some people are beginning to call wasted GDP, which is that part of the economy in terms of production, consumption, trade, which does not translate in human well-being. And so that is an argument And the other very strong argument for degrowth, for inclusive degrowth, is the sustainability one. After a certain level of economic activity measured in GDP per capita, our excess carbon and ecological footprint, if replicated globally, would really make our planet unlivable in 1 to 2 generations. So we need to think twice. So that those two arguments of wasted, and I would call even toxic GDP, because most of that wasted GDP has a price in sustainability and even in inequality, makes us reflect on how feasible would it be to think of a world where we would, particularly in high-income countries, reduce our economic activity, reduce the working hours, have a simpler life, and still enjoy a higher level of well-being. How do you see that horizon?
Well, let's separate two things. One is the way I'd like us to think about it, and the second, is it feasible? I would say that, as you know well, and you've been illustrating, when you get to around $15,000 per head of GDP at purchasing power parities, in terms of life expectancy, you don't get much improvement above that level for a country. I'd like $15,000, which is about $50 a day, to be our benchmark of poverty, not $2.10, $50.
Yeah.
Because you can't live a decent life on $2.10 a day, or whatever the World Bank figure is. We know that. Nobody can. I mean, if you're a subsistence farmer, you can kind of survive because you're not part of the market economy. But so firstly, I'd like our global poverty measure to be $50 a day, not $2 something. Because that means we have the idea that everybody should be able to lead a decent life. But it also means we don't need more than that, which is your point. We could live perfectly well on $50 a day. Most people wouldn't like to live on $15,000 a year in rich countries, but they could. They could. So that's what I mean. Let's separate our concepts of what's possible from how we get from here to there, which is an altogether different thing. I mean, when we were in Rio together, Joe Stiglitz gave me a copy of his latest book. My challenge is to finish reading it before he publishes the next one. I'm not serious. I have read it. It's called The Road to Freedom. And he chose the title advisedly. It's, in a sense, a goodbye to Hayek's The Road to Serfdom. It's saying Hayek launched the neoliberal order, and Joe Stiglitz is closing it with The Road to Freedom.
Yes.
And he talks about progressive capitalism. I think, I was in Stockholm on Monday. The Nordics would talk about social democracy. They know what that is. And that's what Joe Stiglitz means by progressive capitalism. And he would say, and I would agree, that neoliberalism has stopped delivering well-being, health and well-being, to the majority of the population. And if you take the US as the example, we know, I mean, I showed you stagnation of life expectancy in the UK. We've had 14 years of conservative-led government that was devoted to neoliberalism, to unfettered markets. The US life expectancy fell for for 3 years before the pandemic. It fell for 2 years during the pandemic. I mean, it's not doing well. It's falling behind all the other rich countries in terms of health. And what's interesting, you said on one of your slides that in the rich countries, the reduction or smaller Gini coefficient is associated with small improvements in health. Part of the evidence for the relation between the Gini coefficient and ill health came from a comparison of US states. The more unequal the state, the higher the mortality.
Mhm.
A recent analysis, a paper published in October, and I wrote a commentary on it, revisited that correlation. So in 1989, it was true. The more unequal a US state, the higher the mortality. But if you look at 1999, 2009, and 2019, that relation has completely reversed. The more unequal a state, the lower the mortality. And you can see it because states like New York, where you've got this huge growth, hedge fund managers and bankers. So you've got a huge growth in inequality, income inequality, but they have better social programs than West Virginia or Mississippi, that haven't had the same growth of income inequality. They're more uniformly poor. So we need to think about inequality in a somewhat different way, and separate out the obscene levels of income of the top earners, and they are obscene, from what other social programs may be going on. And New York State has better social programs than Mississippi or West Virginia. So it's a more nuanced picture. I think
I don't know if, Aratu, someone wants to come in, please.
Good morning, everyone. It's always a delight to listen to both of you. And I mean, I love listening to Juan and his projections and his estimations, and the idea of too much growth, how harmful it can be for sustainability. And I think I encourage you to you're doing a huge amount of work on these data analysis, and I urge you to publish it in a peer-reviewed journal. I think that is very important. At the same time, I can see the contrast between your views and Michael's, about Michael being very pragmatic, and your views, Juan, are very aspirational. And I think it's good to have a sense of where we should be going, but in practical terms, it may be very difficult to achieve, because I live in the United States. It's where, how could you regulate those things? I don't think it would be possible. It's not possible even to regulate something like healthcare. Imagine regulating growth. It's good to know, though, that beyond a certain point, that the economy trickles up, it doesn't trickle down. I'm not an economist, but that's how it looks like it. And on the other hand, I listen to Michael, and he's working with governments, with cities, trying to implement measures that have been proven to bring equity. And so that working directly with policymakers and keeping track of how they're doing and the progress that they make through those measures is extremely pragmatic. And I think it would be hard if, in addition to the points that Michael is proposing on the Marmot cities, I love that name, the Marmot cities and the Marmot countries, if in addition to that, we wanted to have measures to regulate economic growth, because that's the antithesis of where the world is going. And the countries that have regulated growth or that have controlled growth or governmental, where the economy is centralized, they don't always offer equal opportunity for all. So, or they don't offer a minimum. They could maybe for some time, but cannot always sustain that. And there are also issues about personal autonomy. So I think that it's good to hear both the aspirational and the pragmatical, both of them sustained with data. And it's good to move in I think, Juan, that even if it is aspirational, it's good to know where we could be. So congratulations and to both of you. And it's always a delight, Michael, again, to hear about the progress you're making with the Marmot principle. Thank you.
And Arachu, I will come and visit you. We'll just need to work out when.
Thank you. Thank you. As you may know, I recently launched the Center for Health Equity in Latin America at Tulane University, which is part of the it's going to be proposed, the Institute for Health Equity at Tulane also. Same name as Michael used in London.
Juan, just to say, you'll remember Amartya Sen published a paper a long time ago called The Missing Women. And it relates to what you showed of that in some countries, the women seem to be doing worse. I picked up on Amartya's paper, and in my 2004 book, Status Syndrome, I had a chapter called The Missing Men of Russia. And in the countries of Central and Eastern Europe and the former Soviet Union, the men were missing because of higher burden. And I think that's pretty much what you showed. Some countries, it's the women that seem to be suffering more. And in Russia and Eastern Europe, it was the men who were suffering more.
If I may, thank you so much, Arachu, for your comments. You know how much I value your work and your leadership in so many areas. So I think you've captured very well I put numbers on the global picture which are shocking, and probably proposals which are too utopian, and Michael's work at local level, besides his long-standing work at global analysis and call for action, is far more pragmatic and probably feasible. What I may say is that you've touched upon three venues of action. One is academic, one is local action with local governments, or political action, political incidents. After my 22 years in the European Union, working in Brussels and in delegations for the EU in a number of countries, I have grown a level of skepticism of what political changes may bring about, particularly at global level. You may have some quite inclusive countries, but the world keeps increasing the gap between the poorest and the richest. Michael said the differences are obscene. There's no variable in nature that performs like human distribution of wealth or opportunities. I was looking at the ratio between, for instance, Burundi and the richest, which is Monaco, which is close to 1,000. But when I looked at sub-regional levels, interesting, Colombia in the USA, where the White House is and the Pentagon is, has well over 1,000 times higher GDP per capita than the lowest countries. Those differences translate in a tragic death toll that will not be fixed by local actions in high-income countries. So I think we need to cry out loud that the world can't continue like that. And my hope is that by the ethical concepts of sustainability, young generations probably will keep their carbon and their ecological footprint low, will consume less, will live more locally, will probably, now, as you know, in an eco village and connected with a network of eco villages, trying to live simple lives and in local communities. And by reducing our impact on nature, we will be having economies which are more human, simpler, humbler, and probably more amenable to global equity. And I trust more on citizens' actions now, on citizens' conscience, and changing our lifestyles. And if we get close to ethical threshold in terms of our use of planetary resources, we will probably humanize the economy. That's something also that Joe Stiglitz has stressed in a number of ways. So I see your point, and I count on you to probably have a more academic profile of all this work and analysis. Our next webinar, in fact, has something to do with what Michael was saying. I don't know if you've looked at some of the subnational data, Michael, but in fact, the poorest, I don't know if they call it province or district or state in Japan, I think it's the province, in Japan, which is Nara province, has the highest subnational life expectancy. It is in the top 5 higher life expectancies in Japan and basically in the world, with a GDP per capita, which in purchasing power parity is close to what you were saying. So we don't need to keep hoarding resources. In fact, we have identified something we call the hoarding threshold and the excess threshold, above which basically we're destroying the planet and undermining people's lives. So how can we, from citizens' action, from scientific evidence, and from political dialogues and incidents, how we can put a top on capitalism and neoliberal policies that seem to be gaining grounds now, particularly with President Trump coming and others to the scene. It is a matter of concern. But as I said, I think raising the conscience of people that you can have even a better life with simpler means and in greater harmony with nature is where I keep my hope.
I'm tempted to make comment. Sorry, Michael.
Well, just one minor comment. It's probably not accurate to describe Trump as neoliberal. I think it's a kleptocracy. We're about to see, a sort of oligarchy, which is not really, they don't believe in free markets. They believe in an oligarchy, in a kleptocracy. So it's not even as theoretical as neoliberalism. It's worse than that. It's just plain corruption, which is damaging all by itself. At least neoliberalism is an ideology, and we can say that it's wrong. It doesn't deliver well-being. Corruption is something altogether different.
And if I may, in the spirit of this distinction that Michael is making about being known in neoliberalism. I feel like, and also responding to Horacio, that as much as we need pragmatical course of action, that's this ones that Michael is proposing in his motto, this kind of more aspirational work of one of giving names and giving ways of calculating how we are burning the planet and somehow affecting the possibilities of life is as necessary as. Because if we can't name it, if we can't measure, we can understand properly. So I feel like in they particular can go together, and we are needing words because there's so much change on the things that are going on that is better. And I'm an academic. I feel like we can contribute with evidence and terming things and finding the proper way of putting the problems so we can find the solutions. And never forget, everything that we have now was impossible once. I'm someone who is very committed with the capacity of humans to imagine something different and struggle for it, because this is what we do over the course of our lives. So yes, I like how we can end the last series of the webinar this year will be with this combination of a more pragmatical and already growing momentum inside of particular realities, and something that shows us how to use the pragmatical knowledge about what we have to rethink and reframe issues that we are having under new conditions. So I think as a writer, that's a pleasure to hear both, and I'm convinced that both are equally necessary. Thank you very much. I will unmute you. Juan, I'm unmuting you. Well, you're muted, Juan. You're muted, Juan. We can't hear you.
Sorry, I was saying thank you so much, Michael, for your time. Thank you, Andre, for hosting us. Thank you, Arachu, and all the rest for being here. We hope to continue in 2025, keeping our sustainable health equity movement alive and kicking here and there where we feel there is injustice to be brought to the debate and the action. Thanks so much.
Thank
Bye
you
for
very
now.
much,
Bye-bye.
everybody. Bye-bye.
Thank you. Bye-bye.